I'm Dr. Bruce Holmblatt. I'm the Riverside County Medical Association president. And once again, Dr. Kaiser has kindly said he'll have a meeting with us bi-weekly. I think this is our 5th meeting now, or 6th. But I want to again thank Dr. Kaiser for all his leadership in this crisis that we've had. I really appreciate it, and just saw yesterday that both Stagecoach and Coachella have been moved, or at least are not happening in October, and I do appreciate it. I do think that was the right decision. And having said that, if Dr. Kaiser could kind of give us an update, and then we'll go to the questions.
Well, thank you. As many of you will note, unfortunately, the county has crossed the grim milestone of 10,000 cumulative cases. Some of our recent bumps were due to the Chuckawalla Valley State Prison outbreak near Blythe. This is presently the largest outbreak in the state correctional system. But much of the increases we've seen in the last several days are also due to gatherings which have occurred after Memorial Day. Tomorrow, the state is permitting expansion further into what they call an expanded stage 2, with opening of many sectors such as gyms, restaurants, campgrounds, hotels for travelers, even some theme park components. And we will obviously be watching the reaction to those numbers as well. There is extensive guidance present on the state website. For those of you who haven't visited, you may find it informative. That's covid19.ca.gov. But it should also be pointed out that it is simply that, guidance, and it is incumbent upon all of us to remind our patients, colleagues, acquaintances that social distancing and face coverings are still the linchpin of infection prevention. I don't think it'll come as a surprise to any of us that if there are more cases, there will be more hospitalizations, and some of those people won't make it. We are, of course, starting to look ahead to the fall for what may be shaping up to be the second wave. Dr. Holmblatt already mentioned the Coachella and Stagecoach closure. Part of that, and I know we have questions addressing it, so I won't belabor the point during the introduction, but that's partially why I ordered it closed. And while the models disagree on the magnitude, so far they do not disagree on its existence. It should also be pointed out, of course, and this is the point that's inescapable, that such gatherings would be part of the governor's stage 4 anyway. And the governor has, even though there's been a lot of back and forth on whether we're in stage 2 or stage 3 or stage 2.5 or whatever you want to call it, it is fairly clear we are not in stage 4. And he has said on multiple prior occasions that we would not be entering stage 4 until there is an effective treatment and or an effective vaccine. I know there are some questions about those tonight, and I'll talk about them, but the $10,000 question is, we don't expect any of those things to be likely available, at least not in large enough quantities by the end of the year. And certainly not by the time these things would be taking place. There are, of course, the warp speed trials, and I'll talk about those, and a few of them are targeting having doses available by the fall, but nobody's really certain if they'll have those doses, let alone how efficacious they will be. There's, of course, more to say with the questions below. So, Dr. Holmblatt, I'll give it back to you, but I'll actually take the first two together.
Okay, I'll put them together here. So, questions 1 and 2: are the steadily increasing cumulative cases due to expanded testing? Do you expect we'll soon see that slow down or accelerate? And adding question 2 into that: how soon do you predict the second wave of COVID-19 once the economy opens up?
Some of the increasing cumulative cases are indeed due to expanded testing, but actually we have had some decreases in throughput at some testing sites to the fact the state has actually started telling us we need to improve our utilization or else. So some of the case increases really are also being driven by simply increased positivity. As I mentioned, there was a bump after Memorial Day weekend, and we certainly expected some changes in our epidemiology with reopening. And it was always predicted, and I said this before, that we would still have sporadic outbreaks for the summer. But currently, all of the available national forecasts do show increases starting in August and September. They disagree on the extent and the severity of the peak and how it will affect ICUs and hospitalizations, but all of them so far indicate something, whatever that ends up being, will happen. Now, there is, of course, still the possibility, and Dr. Fauci, for example, has alluded to this, that there won't be one if people start taking advice to heart. But I think all of us know that human nature is what it is. And all models, although they are wrong, some are useful. And the current forecasts indicate that we would probably start seeing these impacts to the healthcare system somewhere around the tail end of summer. The forecasting is less clear for Riverside specifically. We have relatively good forecasts statewide. Countywide, it starts to get a little bit more dicey. Frankly, we as a health department learned our lesson good from the beating we took on predicting too far out too quickly. We ended up just handing a big stick to the people who wouldn't have believed anything I said anyhow. So we are doing much shorter term predictions and adjusting much more frequently. You'll have probably seen that we're trying to go forward instead of several months, trying to go forward to several weeks. Unfortunately, we are meeting those forecasts. The state does have its own forecasts. These do indicate that Riverside County is not anywhere different from anywhere else. The virus isn't gone, and it is certainly not gone from here.
Okay. Question number 3. I love the website. Can we have a 7-day average graph for the number of new cases? That also.
I assume you meant that that would smooth out the Monday spike too.
Yes, my bad. Sorry.
The 7-day moving average is actually on there. If you go to we have a tab, and this isn't well demonstrated, and I apologize, but if you go to the Department of Public Health coronavirus website, which is rivcoph.org/coronavirus. About a little ways down the page, you'll see our map right in the middle. There's some tabs at the bottom of that map. One of them says reports. If you click the reports tab, you will actually get a whole bunch of additional documents. This includes epidemiology by supervisorial district, and there's also one there marked the daily epidemiology summary. If you click on that, you're going to get a PDF document. This actually shows a whole bunch of additional graphs. We generate these daily. On usually page 4 is the daily COVID-19 cases. If you go to that one, you'll see there's a whole bunch of orange bars. That's the raw daily new count number. There is a yellow line there, and that is the moving average.
Okay. Question number 4. What are the demographics of the increase of deaths in California?
Statewide, Hispanics and African Americans are slightly more represented in death tallies than the general population. Whites and Asians slightly less. Deaths, of course, continue to occur disproportionately in geriatric populations. California, for the pediatricians and family practitioners, does not record any deaths in anyone under 18. However, if you are over 80, the state case fatality rate is about 25%. It's about 10% for ages 65 to 79. Our current death drivers, and this has been true pretty much all the way around, including most recently, continue to be primarily in aged populations and the so-called vulnerable populations in those types of congregate living settings. This certainly brings up an interesting point of how do you prevent them. I got a call this afternoon, for example, from a physician who was somewhat frustrated with the facility where they were trying to get somebody back in there. They had tested positive, and the facility wouldn't take them back until they tested negative. And of course, given the way that PCR is, they were shedding junk RNA and still positive weeks after they had clinically recovered. And that's going to be the hard part, because as we start moving towards a strategy where we do retests in these facilities, and there's going to be a lot of discussion over who's the primary responsibility, how often, and so forth, we're still going to end up having to protect them. But as the numbers increase in the general population, for those people who don't live in those settings and rely on having to go out and do their daily activities, it's actually going to make it more dangerous for them. That is still, to this day, the major driver of our death counts, and I don't anticipate that to change anytime soon.
Okay. Question number 5. How is the overflow of COVID-19 admissions from Imperial County going to affect the Riverside County?
Imperial County patients, and for that matter, expats who are coming north for care out of the over the Mexican border, which has been the primary driver of that surge within Imperial County, they are not counted as Riverside County cases by the state, because when we're tagged with a case, that's based on their address of record, and their address of record is not here. However, where it does have an impact is on our hospitalization numbers. The state is trying to figure out a way so that we aren't dinged for it, which is important, because if we're going to be graded on this, then the obvious response is not to take any transfers, and that is obviously not what EMSA wants. The flip side of that coin, however, is they're currently doing it by trying to take numbers off the top, which is somewhat problematic because even though this deals with new admits, it doesn't deal with somebody who may not end up being a rock on a hospital service, which in turn has a long-lasting impact on the system, even if they aren't necessarily contributing to our new cases. Some facilities are also taking COVID-19 positive patients outside of the ordinary emergency transfer system. For example, we know of at least one contractual obligation which is affecting our local hospital numbers, but we still do ask, if at all possible, that hospital transfers should go through the state transfer center so that acuity of care is appropriately assessed. I mentioned this case the last time, and I'll say it again. We do not want a repeat of the COVID-19 non-resident who got shipped to a hospital out here, got discharged from the ED without actually having been admitted, and then promptly got on a bus and exposed all the people on it. We would definitely like to avoid such a situation, so we want to make sure that these hospital transfers are an appropriate level of care. Again, a certain amount of extra system transfers will occur, and there's not much we can do about that. We just want facilities, and particularly if you happen to be on the other end of the phone call, we want those acceptances to be judicious.
Thank you. Question number 6. Many private practice physicians like myself have practices both Riverside and in San Bernardino County. In my experience, San Bernardino assisted our practice with PPE, but not Riverside. What is the plan moving forward to support private clinics in Riverside with PPE?
I can't speak to what ISMA's MOAC system, the Medical Health Operational Area Coordinator system, is doing differently, as they are separate from ours. But in the Riverside MOAC, there may have been 2 factors at work here. The first one that comes to mind is that requests are dealt with as they arrive. We don't queue them up necessarily. And it is possible your request may have arrived after others, which we could fill. But the second and more likely situation, though, is that, remember, hospitals are tiered higher. PPE was doing very well for a while, but we are starting to have a crunch again, particularly for N95. Surgical masks are in pretty good supply, but the N95s are particularly difficult to acquire. And we will still try to serve whoever asks, including outpatient physician offices. Just keep in mind that the Riverside MOAC program is mutual aid, and those who get requests from it may be expected to contribute excess gear into it. As always, as mentioned previously, you can send a detailed request to mhresource, it's all one word, at rivco.org, and we will try to accommodate you. Keep in mind, of course, you may not get everything you ask for on the day you ask for it, but we are trying to serve as many physician offices as we can. I realize that sometimes the system does not have as much visibility into it as I would like, but rest assured, whenever we are able to meet the requirements of a physician office, we will always endeavor to do so.
Okay, next question. It's a little lengthy here. Our hospital policy has been the following. Any patients who are to be admitted to the hospital coming from the emergency room are to undergo a rapid test to determine their COVID status. If they test positive, they are isolated to a designated and secure nursing unit. If they require ICU services, they are isolated to a designated and secure ICU unit. All negative patients who are admitted then can go to any of the other floors as necessary. My question comes up now because we have developed a market shortage of the rapid tests again. Therefore, we have to use these send out tests, which can take anywhere from 24 to 48 hours to get an answer. So those patients who are COVID pending, in theory, these patients should be kept in quarantine in a completely separate area until the results come back. No diagnostic testing should be done on those patients while they are in the pending status, and there should be a significant minimization of employee contact. I bring this up because of this example which happened over the weekend. The patient is COVID pending, and a routine echocardiogram was ordered on the patient. Should that patient be able to go from their quarantined bed down the halls to a regular elevator downstairs to go get the echo done? I was asked to approve this, and I said, no, I would like to know if I was right and what you would recommend in this situation.
I think there are two things that should be considered in this scenario. The first is, of course, the specific issue at hand. My thinking here is this is indeed a routine non-urgent echo, then yeah, it would be best to delay that until the result comes back. We don't believe that asymptomatic or pre-symptomatic individuals are major drivers of infection, but simply it just seems like an unnecessary risk for something that does not need to be done urgently. However, this scenario also brings up the clinical utility of rapid molecular testing versus conventional RT-PCR. Here, the performance characteristic of primary interest would probably be the negative predictive value of the test. For the antigen tests which are out there, they are probably too new to classify. But rapid PCR, at least as a group, does seem to have a poorer NPV than conventional PCR. Now, for asymptomatic individuals, it's probably sufficiently comparable, and I'm going to assume this individual here was asymptomatic because the prevalence in that population was low anyway. But if the individual were symptomatic, not only would they probably not be going for their echo anyway, as long as they remain COVID pending, but the NPV is probably not as good as conventional PCR. I mean, the false negative rate wouldn't be especially high, but just keep that in mind. One thing, though, that has been a real limitation to these rapid tests is, as you say, there has been a tremendous shortage of the reagents necessary. The county actually has 2 Abbott systems. We got them from the state. We're going to use those in many of our testing circumstances, except we can't really get reagents for them. We could get enough to do, maybe, double-digit numbers of tests, and we're running throughput where we require thousands daily. It's just not, there's no way we can scale them up. And the Abbott is probably the one that has the best market availability. Most of the other ones are running extremely low volume. Unfortunately, I see those types of tests being really of utility possibly in much smaller volume settings. And unfortunately, hospitals, even hospitals probably are not able to maintain the necessary throughput to make them useful. But as far as what you did in this circumstance, with the information I have in front of me, I would have probably made the same call.
All right, well, thank you. Question number 8. Is there a good antibody trial on the horizon to provide mass-produced antibodies to sick patients admitted to the hospital and or the ICU?
Well, I don't know if I'll call them good, but there are 3 trials I'm aware of. And the first one is the name, and I wrote this down, is LY-CoV555. This is Eli Lilly's. It entered clinical studies on June 1st. These are all phase 1 safety trials. And this first Eli Lilly is for people currently or about to be hospitalized with a positive test. The second one is an Eli Lilly partner. It's Junshi Biosciences neutralizing antibody JS016. This one is starting June 7th in China, but because they are a partner of Eli Lilly, we are likely to see this particular product come to the United States as well. We don't have any information on it yet. This is also a phase 1 trial. And the third and most recent, and one that's gotten press over the last several days, is Regeneron's Reg-N-CoV2. This is another phase 1, but it interestingly has another arm in it actually for prevention. In addition to treatment, they are also looking to see if it can help prevent infections as well as treat them. They are all monoclonal antibodies to the best of my knowledge. Some of them are murine origin. However, I do not anticipate much data from any of these trials for a while. So like I say, it's hard to say whether they're actually going to be good or not.
Okay, thank you. Question number 10. Is it important to use influenza rates of infection?
I think you skipped 9.
I am sorry. What is the status of the vaccine trials?
Yeah, that was the other one too. I am aware, and I checked on this before I got on the call, I'm aware of about 130 vaccine trials at some stage of investigation. Most of us, I think, will be largely interested in the 5 so-called warp speed trials. These are the ones that are being specifically promoted at the federal level. They're the ones that get the most press, the most money, and hopefully have the most promise. So I'll talk about those specifically. Moderna's mRNA vaccine is probably the furthest one. I believe it is at stage 2 expanded trials. But some serious questions have opened up because its phase 1 testing infamously only collected data on 8 people. That led to one of the sharpest rises and falls in the stock market in recent memory. Next furthest is probably the BioNTech Pfizer Fosun vaccine. This is another mRNA vaccine shooting for several million emergency doses available by the fall. AstraZeneca and Oxford are using a more conventional adenovirus vector. This is entering phase 2, phase 3 efficacy trials in England and Brazil. They are targeting emergency doses being available hopefully as soon as October. Johnson & Johnson and Beth Israel Deaconess Medical Center are also working on another adenovirus vector vaccine using a slightly different carrier. This is to enter phase 1 and 2 trials next month. Finally, Merck IAVI are developing a vaccine using vesicular stomatitis virus as the vector. This is similar to what they used for the Ebola vaccine, but this one has not yet entered the clinical phase. If I were to take bets on any of these, I would probably put it on one of the viral vector vaccines. The Oxford one seems like it's the furthest to market. The early data on mRNA vaccines is pretty promising, but I think they're too speculative right now. And I think that if we're going to need to scale this up to the amount of doses required to really make a meaningful public health intervention, then it's going to
Hello?
We can hear you. Did I drop off?
Yeah, you dropped off for a second there.
Where did I leave off?
You're putting your money on Oxford.
Yeah, that's pretty much it. I think the early data on mRNA vaccines, it's promising, but it's probably too speculative right now. And the advantage of the adenovirus ones is they would probably be more amenable to conventional manufacturing. And really, we just need a whole lot of doses to do anything important from a public health intervention perspective.
Okay, thank you. Question number 10. Is it important to use influenza rates of infection and death rates in conjunction with COVID-19 SARS-2 rates for perspective?
I'm going to actually address this from flu because, even though people have talked about SARS-2, I'm assuming by this you mean the original SARS, the numbers were relatively small in the United States. So I think flu is probably the easiest widespread disease we have to compare to, but people should also keep in mind that flu statistics are in large part computationally generated, whereas every single case of COVID-19 actually does have an actual positive result on the chart. CDC presently uses a mathematical model to compute influenza cases and deaths. It's based on a selection of hospitals and health departments which cover about 9%-ish of the population. Using these ratios, and then they also incorporate test sensitivity, underdetection estimates, and a few other secret sauce statistics. Then they extrapolate out to the rest of the country. Furthermore, test data can often be incomplete year to year, and usually is, so they also use data from previous seasons. Now, I still think the comparison is at least acceptable to some degree, because really there aren't anything of this magnitude to compare it to easily. But people should be aware that the comparison is inexact because of the methodology. And frankly, if COVID-19 has caused us to re-examine anything, well, a lot of the flu data massaging is unavoidable because a lot of the available flu data is also of low quality, but maybe we should rethink that too. I will actually take the next two questions together as well.
Okay, questions 11 and 12. Is it true that future closures are more likely to center around aged individuals as opposed to a complete economic shutdown? And question number 12, are there any studies ongoing that are tracking the morbidity and mortality that occurs from general economic shutdowns as well as general healthcare shutdowns? As an example would be a patient not able to see their physician for workup of a serious condition.
When we've been looking at what will happen if the numbers shoot up substantially, they've posed this question to the governor, and he's essentially said in so many words, they're not going backwards on the rollout. With this in mind, it is also demonstrated, and I think well proven in history, that those regions that have implemented prompt non-pharmaceutical interventions over time did the best. That probably means that if there were a fall second wave, and if it were bad, the types of orders that would likely appear or reappear would be behavioral in nature, such as social distancing, face coverings again, potentially something that would come down from the state level. And there would also be a greater emphasis on enforcement of guidances which right now have been pretty much on your honor. I expect that there would be more formal structures set up to actually make sure that people were doing those, rather than to bring back what we saw way back in the beginning, which is the essential versus non-essential distinction. That caused a lot of headaches. A lot of people thought they were essential and they weren't. It was sometimes very arbitrary to figure out what that meant. In fairness to the governor, they have tried to move towards a more risk-based approach with these guidances. But I expect that I would see that the guidances then would get some additional teeth put in them. I do imagine that there are some ongoing studies which are attempting to address the downside of shutdowns and quantify the societal cost. And that's absolutely appropriate. That kind of thing does need to get factored into the computation. I am not personally aware of any, although I'm sure they're out there. But these studies are, like many such political analyses, subject to the respective biases of their investigators. And I think there's going to be a lot of debate over their validity. The question specifically about the shutdown's delay of preventive care, this has been talked about a fair bit. We have certainly seen as one visible factor impacts to pediatric immunization rates, as well as delays in other kinds of regular visits. Now, I also suspect the extent to one thinks these are outweighed by the coronavirus response and the potential impact it addresses will, of course, be colored by one's own personal view. As I'm starting to say a lot more often these days, it is sometimes very difficult to distinguish a public health intervention that worked from a public health intervention that was not necessary. You can second guess this to death about what happened on there, and I won't belabor the point in this forum. I expect that we will see these analyses, they'll rage back and forth, but the rubber is going to meet the road in the fall. If these models turn out to be correct, then we're just going to have to figure out what we can do to try and step it up, because we'll have to do something.
Okay, well, thank you very much. If you have time, there are 3 to 4 questions in the chat room. Do you have time to answer those also?
Sure. Actually, I can see them, so I'll just read them off.
Okay, that's fine.
The first one, it's from iPhone, and it says, in regards to remdesivir allotments to Riverside County hospitals, would it be okay to share supply with other hospitals in different counties? For example, if our sister hospital in LA County has need for remdesivir, can we transfer part of our supply to that hospital? And can we accept the supply from other county hospitals? We would prefer that you didn't do that. Part of the reason for the remdesivir allotments going through the MOAC program is because they are a very limited source. And even though we've gotten a fairly good slug of it, we certainly don't have enough for everybody who could potentially benefit from it. Especially for out of county areas, those counties are getting their own allotments as well. And if you believe that you are not making good use of the remdesivir, we would like to know about that and reallocate it. Similarly, if it's moving between hospital to hospital, we really have no visibility as to where it's actually going, and we are ultimately accountable to HHS for the doses that we happen to distribute. So I would strongly discourage this. If you believe that your doses would be better served in another facility and you have the epidemiologic information to justify it, we're all ears. You can contact me directly about that, because much of the time I'm the one who's actually generating the numbers about where the remdesivir goes. So reach out to me. Email is the best way, ckaiser@ruhealth.org. If you believe that there's a misdistribution, or you think that they're, based on what you're seeing in the facility, that they could be beneficial going somewhere else, then talk to me about it. But definitely do not move them out of county.
Okay, thank you.
And the next one I see is from Dr. Fahim Jukaku. So vaccines would be available in Riverside in 6 to 8 months. Maybe. I'm not taking that bet. I think that there is a lot of optimism about that. He wants these to succeed. And frankly, I think for us to meaningfully enter stage 4 and get back to whatever passes for normal these days, we're going to need to have it. 6 to 8 months from now, of course, would get us falling right in the middle of winter. So it's, I think the most instructive thing to look at would be H1N1. In 2009, are you still hearing me? I just got a note that my internet connection's unstable. Did I drop out?
Just for a second.
Okay. If you look at H1N1 from 2009, that vaccine came down the pike in 6 or 7 months, as memory serves, which, I think a lot of us thought was awful quick at the time. But the reason they could do that is because they were really just entering a different serotype into an existing vaccine manufacturing pipeline. And of course, H1N1 is now a standard component of virtually every annual flu vaccine. Whereas we're dealing with an upper respiratory tract infection vaccine for something which we don't really have coronavirus vaccines for, at least not in human medicine. I think that there would be some sufficient issues with getting enough doses on the street by then. My main concern is that there's going to be some doses, but not enough for everybody to get the vaccine who wants to get one, which is going to be problematic in 2 respects. Number one, who decides who to get it? And number
Right.
2, there's not going to be enough around, because whatever vaccine it's going to be, it's going to come down so quickly that I think there's going to be serious questions on its efficacy, which means you're going to need to inoculate as many people as possible to really drive up that community immunity that you want, but there's not going to be enough of it to be around. While I think that the time frame of 6 to 8 months is possible, I'm not sure how plausible it is, and I'm not sure how feasible it end up being. And even if vaccines happen to be available, my worry is that the quantities will be so low by that time as to not be particularly useful. Time will tell.
You're fading out on us.
Did I? I said if I were to bet on one, it would probably be the adenovirus.
Are there any other chat questions on there?
No, I don't see any others. There was just that 2.
Okay. Well, thank you very much, Dr. Kaiser. You once again been very informative, and appreciate everything that you have done for our community.
Well,
Thanks again.
As we say, the ride has not come to a complete stop, so I'll be updating you later.
Okay. Thanks again, Dr.
Take care.
Kaiser.
Good evening.